Okay, so when we talk about ACLS, we talk about a lot of times death, when death occurs, and we're talking about basic life support, and then the next step would be advanced cardiac life support. But ACLS can also mean advanced care as needed, like advanced medications or advanced knowledge or advanced expertise in those areas. And so then we would go to those areas. So when we talk about too fast from the top part of the heart, too fast from the bottom part of the heart, too slow and dead, then when we're talking about ACLS, that comes into play. So we talk about the steps of the basic life support, and we can kind of see that. But we're going to focus on why we have this. American Heart Association got together with different hospitals and places around the country and saw how everybody treated everybody. And it was different. And so they looked at what's the best available evidence we have, and then also included worldwide consensus and developed the guidelines with best available evidence and worldwide consensus in mind, and provided us with guidelines and treatment algorithms so that kind of everybody knows what everybody else is doing and everybody knows what the next steps should be. And again, they're guidelines, so it's not set in stone, but it's the guideline that we should consider based on the evidence. And then if we have expert consultation that says, let's do this, then we can deviate a little bit from that standard. But the guidelines are released every 5 years. And so they should be coming up in 2015 at the end of the year. Okay, and so this shows the algorithm. This is what the tachycardia algorithm looks like. And so generally a heart rate greater than 150, we start seeing arrhythmias. Technically anything over 100 is tachycardic, but anything, but typically you wouldn't see arrhythmias until it's greater than 150. That's generally the case, but everybody's a little bit different as well. So we're going to treat the patient, not just what the monitor is showing. And then we're going to look and say, hey, we need to make sure the airway is patent, and are they getting enough oxygen, and put them on a cardiac monitor, and then ask some questions. You know, with this fast heart rate, we have a cardiac output equals stroke volume times heart rate. Now, that as long as the heart rate goes up, generally cardiac output will go up. But if it goes up too fast, or it can't fill, then our stroke volume will drop, and then our cardiac output could drop. So how do we tell that? Check pulse, and then, right, you check for blood pressure, and say signs of acute confusion or changes in mental status, signs of shock, ischemic chest discomfort, acute signs of heart failure. All of those would say, hey, the patient is unstable and we need to be treating them with cardioversion. Now, otherwise, we have to say, is it narrow? We'll treat them this way. If it's wide, we'll treat them this way. And so this is just going to follow each of that guidelines around. We're going to go through the narrow complex tachycardias first. Okay, and so with any strip, how do we do the interpretation? We find there are 6 seconds. We count our rate. We see if it's regular. Is it sinus? Do our PR interval and QRS complex and QT interval. So in this case, we're saying that the patient is alive. So they're either communicating with you or in some way you can see that they're alive. This is 6 seconds. I'm going to tell you that. And so you don't have to sit there and count the boxes to find the 6 seconds, but I'm just going to say that's the given. So what would I do next? Right, they count the R wave. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Okay, and so 15 times 10, get your calculator watches out. That's right, 150. Good job. Okay, and in this case, is there a P with every QRS complex? And there is. It's kind of dug into the T wave a little bit, but we do see that it's the same shape, and there is one with every QRS complex. So we measure that, and it's about 5 boxes beginning of the P to the QRS complex, and so that's be 0.20. and our QRS complex is about 2 boxes, 0.08, and our QT interval is about 6 boxes, so it's about 0.24. So we don't have to worry about medications that would increase or prolong the QT interval, so that we're within that range as well. So the stimulus is coming from the top part of the heart, and we know that it's a sinus tachycardia. So ST 150, PRI 0.20, QRS 0.08, and QT interval is 0.24. Okay, so we see this as another narrow complex tachycardia. So we'll look at it and say, this is a 6-second strip, but you could determine it by looking at the larger boxes and counting them. But you're 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 times 10 is, that's right, 120. So you see, hey, this looks a little bit different because there's no discernible P wave like the rounded P wave. You've got these sharp saw-like, like if you look on a saw blade, you see these tooth jagged saw-like teeth on them. It's kind of a classic sign of atrial flutter, where the top part of the heart is just fluttering and not enough to fill, so it's sloshing all this blood around, so it puts them at increased risk for stroke. So it's too fast, it's not normal, and it's got these flutter waves, so no discernible P wave or QRS is about 2 boxes. QT interval is about 10 boxes, so 0.40, and it's atrial flutter. Okay, and then so next we have another narrow complex tachycardia. And so again, I don't care if you know all of the names to these. As much as I want you to know that it's a narrow complex tachycardia, and then we'll talk about how to treat that. But if you can recognize that, it's the same group of medications going to treat all of them. So you don't necessarily have to memorize every single rhythm. But we count our R waves here. 6-second strip, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 times 10 is 120. Good, and again, no discernible P wave. A couple of places that looks kind of like there may be, but it's not consistent, doesn't look the same with every one. There's not one with each QRS. So it's not sinus, and it's irregular. The R to R is irregular. That's kind of another classic sign. This is atrial fibrillation, and so the atria are just fibrillating. And again, our atria we don't have as much love for as we do the ventricles, because the ventricles are our main pump. So when you hear the term fibrillation, well, some students will say, oh yeah, I remember he said that was bad. But it's not the fibrillation that's as bad as what chamber it is. Is it the atria or the ventricles? If it's the ventricles, it's bad. If it's the atria, yes, it's some it's a cause for some concern, like for stroke, but it is not you will not probably die from it right this second. So be kind of cognizant of that. So this is irregular tachycardia, 120, no discernible P wave, QRS 0.08. QT interval, we're not really able to tell because not really see a T wave there. So which would be something we could report to the provider next time so they come around, or if we had to call them. And then they might get a 12-lead EKG or investigate that a little bit. But this is our atrial fibrillation. Okay, and this one you will have to determine what the 6 seconds is. So the little tiny boxes are 0.04 seconds, as you remember, and 5 of those makes up a larger box is 0.20, and then 5 of the larger boxes makes up 1 second. So you can find, you see little marks at the bottom of the strip, and you can say from one mark to the next mark, that's 1 second, to the third mark's 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds, and then you count the number of waves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So 18 times 10 is what? That's right, 180. And this is regular. The R to R is regular, narrow complex, and no discernible P wave. So it kind of looks like sinus tach, but there's no P wave here. So that's kind of classic of supraventricular tachycardia, or above the ventricle, supra above. And this is called SVT, or supraventricular tachycardia, and it's regular. And so we'll talk about the treatments in a little bit, but how would we kind of write this down? So regular tachycardia at 180, no discernible P wave. QRS is about 2 boxes, 0.08. QT interval is about 6 boxes, so about 0.24. So that would be our SVT, supraventricular tachycardia. Okay, so what do we do about it? So ACLS says, hey, once you've kind of identified the rhythm, then you need to ask some questions or provide some assessment here. And so what's your assessment going to be? Okay, if it's so fast, we talked about that cardiac output equals stroke volume times heart rate. If it's so fast that the stroke volume drops and our cardiac output drops, then the patient's going to start showing some signs and symptoms of problems. So we're going to say that any of those yeses, with any of those questions, is going to be signs to go, we'll call that patient unstable, and we go right to synchronized cardioversion. So if we get a pull, we have a heart rate that's 150, we check a pulse, so the patient has a pulse. So we check the blood pressure, see if the patient's perfusing well. If it's low, altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, those kind of things, we're going to say, hey, let's go right to synchronized cardioversion. So we get the crash cart, call the provider, get the charge nurse in there with us, get RT notified, so in case the patient needs to be intubated, we can do that. But patient's alive, awake, so the patient may need some sedation. So we're going to go in there and bring the defibrillator in there, hook up the patches and everything, but we're not defibrillating, we're synchronized cardioversion. Defibrillation's for dead people, synchronized cardioversion's for alive people. So there's a sync button on the defibrillator. We push the sync button on, and you see at the bottom it marks the R wave. The T wave is the most vulnerable point of the process of the electrical conduction system, because the ventricles are repolarizing. So on that T wave, we don't want any electrical stimulus on this T wave. So the synchronized button, the sync button, will mark the QRS complexes and allow the electrical shock to come on to the R wave and not on the T wave. So in this case, it shows where it's syncing, it's marking it on the R wave, we shock the patient, and then the patient goes back into the normal sinus rhythm. That would be great. It hurts the patient needs to be sedated and have an amnesiac like Versed or something like that, so they won't remember the incredible amount of pain that would cause them to help fix this problem. Okay, so if the patient is no to any of those questions, so all of those questions are no, they're not hypotensive, not having chest pain, not acute mental status changes, not signs of shock or heart failure or ischemic chest discomfort, any of that stuff is no, then instead of synchronized cardioversion, we're going to do medications. And some of the medications would be beta blockers. So the classification of beta blockers, there's beta receptors in the heart and there's beta receptors in the lungs. And beta blockers, a beta agonist will increase heart rate, dilate the lungs. Something like albuterol, which is not for this, but it's a beta agonist, whereas this is a beta blocker. So beta receptors that are blocked in the heart decrease the decrease the heart rate and the force of contraction. And so it decreases the workload on the heart and helps lower the rate. So rate control is our main concern, that we're trying to get the rate into a more controllable deal, so that as the heart rate comes down, the stroke volume will go up and our cardiac output will be better if we get rate control. So heart rate and contractions decreased, and then on our respiratory side, it causes bronchoconstriction. So contraindicated in restrictive lung disease such as bronchitis, emphysema, COPD, those kind of things. So beta blockers technically are OLOL. Some medications will just end in LOL, and so they may have beta blocking properties, but they also may do other things. But true beta blockers are OLOL and will decrease heart rate and the force of contraction. And be cautious in patients with restrictive lung disease. Okay, calcium channel blockers. Now, remember we talked about this a while back, and we talked about calcium being, you'd have, there's a picture of a heart muscle, striated muscle, and in order for it to pull together and contract, it would pull the ionized calcium into the calcium channels and utilize that as part of its stretch to contract. So now we have a medication that blocks those channels. So the ionized calcium can't get through to the muscle to bind with it. Those calcium channels are blocked. So generally it causes vasodilation and decreases the blood pressure. But two medications kind of act more like beta blockers in that they reduce heart rate and blood pressure, and that is verapamil and diltiazem. So they're commonly used because for rate control, to get the heart rate back down to where our stroke volume is not so bad, and potential side effects are also lowering the blood pressure. So we've got to be very cautious of that. Anybody on an IV infusion, we're going to watch the blood pressure monitor every 15 minutes. So diltiazem is the drug of choice for treating atrial fibrillation and atrial flutter by controlling the rate. So we will watch that real closely. Okay, and cardiac glycosides, the most common is digoxin. And the one thing I'd say about this is comes in a glass vial, and it is not a rescue drug. So if you're wanting some rate control right now, you're not going to get it. It's going to take about 6 hours to take effect. So many times you'll see a bolus dose given, and then 6 hours later the routine dose given. And once the routine dose is given, you start seeing some rate control. But if you're trying to do something right this second, it's going to be a second-line drug. You're going to give something else in addition to this, maybe this bolus, because this is going to be for later. There's not been a lot of studies to show that it improves outcomes, but symptom management has been effective for. So you see sometimes patients have it. Careful of visual disturbances for overdose. The halo, green or yellow halo effects around people is common. Low heart rate, it decreases the heart rate, negative chronotrope, but positive inotrope, in that it increases the force of contraction. It's in a glass vial, so when you break the glass vial, you take a 2x2 or a alcohol pad, and you put your thumb in the little kind of divot of the neck, and you pull back towards you so the glass goes away from you and not toward anybody else. And you have to use a needle, a filtered needle, because you're going to drop the solution, and then you're going to capture glass in there. And so then what do you need to do with the filter needle? That's right, get rid of it from the needle box, and you have to get a needleless system or needleless attachment to give it to the patient. So it needs to be given over 5 minutes, and that's at the minimum. So if you start giving it to a patient, you start to see the heart rate's lower, and you say, well, I'm giving it over 5 minutes. Well, look at your patient condition, not just that you're following the book. The minimum is 5 minutes. So the maximum would be longer if the patient condition warranted. Does that make sense? And then there's a therapeutic drug level for digoxin that I want you to look up and be familiar with. And you should be able to find that on your pharmacology guide. Okay, and amiodarone is another drug. Can be used for both narrow and wide complex tachycardias. It's been given an IV infusion, given as a bolus over 10 minutes, 150 milligrams, and then hang another bolus for 6 hours, and then a routine maintenance dose. Has to have a filter on the end of it. Sodium, potassium, and calcium blocking agents, alpha and beta adrenergic blocking. So it treats several things. Watch the blood pressure. Should help convert the patient to actually convert them to a normal sinus rhythm. So that's kind of the purpose that we're going to be giving it for. So watch the blood pressure real closely every 15 minutes and evaluate whether it's being effective and continue to monitor them. They might need to be put on oral doses. Let's say they convert, then we might be left on the drip for a while and then start an oral dose and then DC the oral dose, the IV dose a little bit after you've already started the PO dose. So those kind of things we will watch and take care of, but it does treat both narrow and wide complex tachycardias. And adenosine is kind of a unique drug, but it's the drug of choice for supraventricular tachycardia, or SVT. And so the problem is that the half-life is only about 6 to 10 seconds. And so you have to give it up in a high vein, closer to the heart, so at least antecubital or higher. And you get a 3-way stopcock and take your flush and your drug. And so, because you're not going to have time to switch them out and all that, you have to give your drug and give your flush immediately. And so it can, so it won't expire by the time it gets to the heart. And what you're going to have is a crash cart, physician, another nurse, RT available. That way, because the risk is also that we're going to obliterate everything in the electrical system so that the normal SA node takes over. But what it always does is put the patient in a systole for a little bit. So at first you're like, oh, goodness. So you're like in slow motion going, get the crash cart, the patient's in a systole, and then you see the rhythm start back up. Either it'll go back into the SVT or it'll change the a normal sinus rhythm. And so, but it will put everybody in asystole. So no matter how much you know that, or how many times you've seen it, it always kind of takes your breath away that you go from a perfusing rhythm to a non-perfusing rhythm for a few seconds. Then as the drug expires, it either converts the patient or the patient will go right back into the SVT. So those are the things we would look for. It is contraindicated in asthma patients because it causes bronchoconstriction, so be aware of that. So regular rhythms with narrow complex rhythms, adenosine would be the drug of choice to use. And here again, I'm going to just give you a few minutes to try and reflect on what's been taught. I would like you to be able to teach this to somebody else and make sure you have this. So I'm going to give you a few minutes to write this out on a piece of paper and teach it back to me or teach it to somebody that you know. Good. Keep going. I'll give you about a minute more. All right, guys, we'll just go ahead and wrap this up. You guys have done a great job. Thank you.